I want to thank the staff at the hospital for providing this for us. And tonight we have Dr. Evan Cohn, Medical Director and Chairman of Emergency Services at Montefiore St. Luke's, Cornwall. He is an emergency medicine physician serving the New York City area. Dr. Cohn is board certified by the American Board of Emergency Medicine. He received his bachelor's degree of science from Syracuse University in 2003 and graduated from the State University of New York, Upstate Medical Center in 2007. He completed his residency in emergency medicine at Cooper University Hospital in Camden in 2010, and he's been in practice for 12 years. So Dr. Cohn, thank you and welcome.
Thank you.
And Dr. Sharam Ahari, Associate Medical Director of Emergency Department at Montefiore St. Luke's, Cornwall. He has over 8 years of diverse experiences, including 5 years of being a pandemic epidemiologist. He graduated from the University of California, Davis School of Medicine with his medical degree in 2013 and holds a master's degree in public health and infectious diseases. Dr. Ahari is licensed to practice by the State Board in New York. I want to thank you. I want to welcome you, and I'm turning the program over to you. Thank you so much.
Thank you.
Thank you so much, Brenda, and thank you for everyone that's taking time out of their busy schedules to join us and talk a little bit about COVID and the flu. And we're going to try to cover some of the pathology, epidemiology of COVID and flu, and a little bit of apples to oranges comparison. Talk about some special populations like children, like pregnant women. We'll talk about vaccines and boosters and third doses, and some of the current treatment options and what's coming down the pipeline. There's so much out there in the news and literature. We're not going to cover everything, but please ask questions. We're happy to answer anything that we can and cover as much as we can in the window we have. So thank you again for joining us. So just to start, I think this is interchangeable terms at this point, but COVID-19 is the disease that is caused by the virus, SARS-CoV-2, which is a type of coronavirus. And there are many different types of coronaviruses which have caused common colds and different illnesses in humans for thousands of years. But this one is the SARS-CoV-2 virus, which causes COVID-19, and we'll use those terms a little bit interchangeably. COVID is spread, as we know, mainly from respiratory droplets, which are large particles that come out of your nose or mouth when you cough, sneeze, or talk. And we know that there is some role for aerosolized particles to spread disease as well. Those are smaller particles that can travel greater than 6 feet, kind of linger in the air. And we know there's a role of that with COVID. The respiratory droplets, which are a little larger, tend to fall out of circulation within about 6 feet. And that's where those kind of 6 feet rules come from. It's the prevention of respiratory droplet spread. The symptoms, one of the things that makes COVID so difficult is that people will be asymptomatically spreading the virus for somewhere up to 4 days before they start feeling symptoms. So you're walking around feeling fine, but as you speak, you may be spreading viral particles. And then once people start feeling symptoms, usually they're able to transmit the virus for another 10 days or so after that. Some of these slides were made before the widespread adoption of vaccines. So, these numbers, when we talk about what percentage of people get what, that's really not taking into account vaccinated population, but assuming unvaccinated, most people will have mild symptoms and about 20% will have severe or critical symptoms, needing to be in the hospital, needing supplemental oxygen. And they're very similar to flu-like symptoms, just probably more severe in general. Muscle aches, diarrhea, lack of taste and smell, headaches, sore throat, vomiting, cough. And most people will start to feel better after 10 days or so, but we know that some people can have lingering symptoms for a few weeks. And the main complications we think about with COVID, at least in the acute phase, would be respiratory failure. You're unable to breathe due to pneumonias, heart attacks, blood clots, and strokes. And then Long-term effects, we do know what's kind of unique about this disease. There's about 30% of people that will become what we call long haulers, and that means they have effects that are lasting weeks or months beyond their acute infection. Some of these are really easy to explain, like scarring in the lungs, causing long-term shortness of breath, injury to the brain or kidneys leading to long-term problems. And some of these are more challenging to explain, like difficulties with memory, concentration, longer-term fatigue.
So we wanted to give you a sense of the impact and implications of what a pandemic really entails. And when we talk about the number of people affected globally, these numbers can be really abstract, but I wanted to throw this out there. I want you to all think about how many people you think have died globally since the pandemic started about 20 months ago, and give yourself a number in your head, how many people have died, and then compare it to what we know, at least in terms of confirmed cases. If you want to pop it up, Evan. So we have nearly 5 million people dead from the pandemic. It's, again, these numbers can be a bit of an abstraction when they're that high. I can say it's the population of Alabama, but even that still kind of makes it vague and abstract. I can say it's the population of all of Manhattan, Brooklyn, and Staten Island, dead from a disease that previous to 20 months ago was unknown to mankind. But it's, again, sort of a vagary. So if we bring it down to the US population in terms of how many people have died in the US, we can pop that one up. We know that as of last week, over 700,000 people have died in the US. And again, that's a number that's also very difficult to process and really gauge. I guess if it's any easier to interpret, that means that 8,000, on average, 8,500 people have died every week for the past 20 months due to a disease that, again, didn't exist 2 years ago. In our community, New York State, we know that 2.5 million confirmed cases have occurred. There's probably a lot more in terms of unconfirmed cases. And in terms of deaths, 55,700 confirmed, possibly more from unconfirmed cases. That's twice the population of Newburgh, which again is chilling as a statistic, and it's, again, still difficult to conceptualize. Those are the right below that are the statistics local to our county. And if we go to the next page, all these numbers can be probably put forward in a slightly easier way to interpret. 1 in 8 New Yorkers have had a confirmed COVID infection, meaning that everyone knows at least a couple of people who have been sick from COVID. 1 in nearly 500 Americans have died from it. And more accurately, 1 in 360 New Yorkers have already died from COVID. That also means that, unfortunately, everyone knows at least one person, whether directly or indirectly, that have died. And the thing that's concerning is that the scope is really unprecedented in terms of an infectious and novel infectious disease. You kind of have to go back to 1918 and the Spanish flu, the pandemic of 1918, to get numbers like that in terms of an infectious disease running and ravaging our communities. So it is a bit mind-boggling and disheartening to process. The flip side of that, unfortunately, is that when so many people have had confirmed COVID, and you've seen it in a number of people in your community, it can also lead to a false sense of security, meaning, oh, I know plenty of people who have been sick and it's no big deal. I think that's a really dangerous thought process that a lot of people fall into. Lastly, and really the bottom line of all these statistics, if you want one more, the odds of being hospitalized in terms of unvaccinated versus vaccinated, 17 to 1. And that's probably an understatement, meaning that if you do get sick with COVID, which is still a possibility when you are vaccinated, your odds of actually being so sick that you have to stay in the hospital is 20 times less. The course, the intensity, the severity of the disease, and your chance of simply getting the disease are all reduced when you are vaccinated. Let's continue, please.
Sure. And just as favorable as those odds are, in your favor if you're vaccinated, they become even more favorable when you look at deaths from COVID, for vaccinated and unvaccinated people.
Yeah, for sure.
So this, I just wanted to touch briefly on, the population of children. And as a parent to two young school age and nursery school children, this is kind of constantly on my mind and in my discussions. With the Delta variant over the past few months, there has been a significant rise in the number of pediatric hospitalizations. There's a really variety of reasons for that, which we can, touch on a little bit later. But what is reassuring is for that adolescent population, the protection from the vaccine is holding up on Delta variant, and for the children as well. Those adolescents are much, much less likely to be hospitalized when they've been vaccinated. I think it's important to put that number, that 10 times the number of pediatric hospitalizations, into context, though, because it's pretty scary as a parent to hear that. This is a graph showing the hospitalization rate per 100,000 cases for children from the beginning of the pandemic up through last week. And, really when we started last March, the rate was very low for pediatric hospitalizations, around 0.1 or 0.2 per 100,000. And it is true, there has been, nearly a tenfold increase to 0.8, 0.9 per 100,000. And just to compare that, and I didn't put a slide on this, but the over 65 population, for comparison, without the vaccines, again, their risk of hospitalization was somewhere between 50 and 20 per 100,000. So, somewhere between 20 and 40 times more likely to be hospitalized. And then just to give it a different context, when we think about what is the risk to me, what is the risk to my family or my children, you start looking at the risk to other things that, we know causes a lot of harm to our children. And so I just put this for comparison. This is the rate of deaths related to guns for children over the last 10 years or so, broken down by state. And the column that, really is of interest here is the second one from all the way to the right, where it says the 2008 to 2017 average. So the risk of death by a gun to a child in this country is somewhere between 2 and 10 per 100,000, which is obviously many factors higher than the risk of a child needing hospitalization from COVID. And then, just looking at, again, the amount of deaths in this country has been around 500 for pediatric COVID since the start of the pandemic, which obviously each one is incredibly tragic. But as a percentage of the total population and COVID deaths, it's really quite small. And then, I think this has been a little bit less in the news recently, but, there was a lot of discussion and worry about this MIS-C, which is the Kawasaki-like illness where, children can really have a lot of multi-system inflammation and organ failure, can follow a COVID infection a few weeks or even a few months after infection. On this slide, the blue line is the MIS-C cases and the dotted gray are the COVID cases. And what you'd expect is an illness that's following a COVID infection. The graph follows by a few weeks. So there have been a few hundred MIS-C cases throughout the country since the start of the pandemic. And certainly on the tail end of the most recent spike of Delta variant in August, September, October, we'll be keeping an eye on those numbers to look for increases. Still quite a rare disease, but something to be aware of. And, as we factor in our risk tolerance and, concerns of COVID, something to pay attention to.
Let me see if I can break down a little bit of Dr. Cohen's slides into something, again, a little bit more digestible and bottom line it a little bit. The upshot that I take away from these slides is that children and adults experience COVID differently. A lot of kids catch the infection. In fact, we suspect a lot of it is going around the community but markedly fewer of them actually get really sick from it. And by really sick, I mean require hospitalization. So it's relatively reassuring in that many kids are likely to get COVID and not experience much in terms of symptoms. And the ones that do get particularly sick are those who are under 1 year old, or those with significant comorbidities like asthma or some congenital heart problem, gross obesity, diabetes, things like that. But on the flip side, unlike adults, the ones that do get hospitalized, a higher proportion of them tend to get more severely ill, which means that children are relatively safe from getting hospitalized, but the ones that do are more likely to experience a much harder course than adults, at a higher proportion, if that makes sense. It's a little bit tricky, but it's a concept that I think hopefully we can take and get a little bit more, if you understand it, will give you a little bit more guidance as to how you want to protect your children. Go on to the next slide.
Sure. And I would just add, and this may be in the next slide, but, when you're factoring in risk and behavior, I do think healthy children especially have an incredibly low risk of serious illness, but, still act as vectors of disease and people that can spread disease. So when we think about a public health perspective, keeping the children safe has, pretty broad implications.
Yeah. Again, tying into what you were saying earlier about how the disease progresses, Dr. Cohen, a lot of kids will actually be infectious without really having much in terms of symptoms. And there's quite a bit of discussion in scientific circles about kids going to school and getting it from another student and bringing it home to family, or vice versa, getting it from one of their family members at home and then bringing it to the school, which is, both are plausible and common mechanisms. And also, as a reminder, again, this disease has only been out for 20 months, so we're still learning a lot, and we're doing our best to give you the most up-to-date and comprehensive information that we can, so that you have something to take away to give you a little bit more guidance as to how you want to protect your family and decisions you want to make for yourself and your community. This particular slide, also encouraging, really the last 2 point, no, the second to last point. We now have FDA clearance for Pfizer vaccination for kids over 12 years old, and already we have 12.7 million US children who received at least one dose of the vaccine. And then again, to offset that, one of the things that we really worry about this population are the proportion of kids who might experience that long hauler syndrome that Dr. Cohen mentioned. The consequences of having organ scarring are really not studied. We're not sure if those who experience prolonged symptoms and experience some organ injury will actually recover from them, and if so, in what sort of time interval. Someone asked the question, do you recommend all children receive the vaccine, or only if they have comorbid conditions? I don't have children, I only have pets. I certainly have an opinion on this, but I'm going to let Dr. Cohen, who has two delightful little ones, answer first. I already know his answer.
Yeah, so personally, my children are healthy, but I certainly would be anxious to get them vaccinated. I do feel that they're being healthy children and not in that age group of under 1 year old are going to be at really, really low risk. But I do think the vaccines are going to offer additional protection and make it as close to zero, and nothing is zero in medicine, but as close to zero as possible. I do want to read the studies and see what the safety data looks like when that's all available, and I'd expect it will be within the next 3 to 4 weeks from Pfizer, looking at children ages 5 to 11. I think this main safety concern that's popped up has been this risk of myocarditis. And my best understanding of it this moment, and that will change over the next few weeks, but that the risk of getting myocarditis from the vaccine is significantly lower than the risk of getting myocarditis from COVID. And even further, that the risk of myocarditis from the vaccines are quite low. So my instinct is going to be yes, they will get vaccinated, my children, but I certainly will read the safety data and try to be objective as I can about it. And then as Dr. Ahari mentioned, most of my behavior will be selfish about what's best for my kids, but I certainly would like to contribute to slowing this thing down as much as we can.
I have a lot of nieces and nephews, and I think you pretty much nailed it on the head. That's the guidance I'm giving my own family. Let's talk about the flu.
Oh, did we do?
Oh no, pregnancy. Okay, before we go to the flu, another population that's at risk is the pregnant population. There are guidelines now in place strongly recommending vaccination before, during pregnancy. And so far, all the data that I've seen actually is very encouraging. It's reassuring. There's little evidence of any potential consequence to the fetus or the mom, which is good in terms of a risk-benefit ratio or analysis, because unfortunately, getting COVID in pregnancy causes typically a more severe course. Your chances of being hospitalized, your chance of having severe disease, death or permanent disability, and your chance of having a preterm birth or a stillbirth, or requiring the newborn to go to the neonatal ICU, go up dramatically. Like Dr. Cohen said, we don't have guarantees. Everything is still relatively new. The best we can do is weigh the risks and the benefits and try to come up with the most logical plan and play the odds in our favor. This one is low-hanging fruit. The odds of something terrible happening to both mother and child are typically markedly much higher in the unvaccinated population. And again, I think this is probably the same for both of us, but everything we share here is really the same advice that we give to our own family.
I think the question that comes up often in the emergency department when we're talking to patients about vaccines is, I'm thinking of getting pregnant, both from men and women. I'm thinking of getting pregnant. I'm afraid of how it's going to affect, the baby or my ability to reproduce. And we took this out of, we've done this presentation a few times, and we've removed the slides on how the vaccines work. But really, there's no, mechanism that it goes to affect, the eggs, sperm, embryos, alters DNA. It really is the vaccines, the mRNA at least, they're just sending your body a message to create a protein that looks like the spike protein. And then your body does the rest. It makes antibodies against that the same way it would if it saw a cold virus or, a flu virus or anything else. And then that message that, the vaccine sends is disintegrated and out of your body in, pretty short order. It doesn't stop in the, ovaries or eggs to make any adjustments. And so really, both what we see practically and clinically and from a scientific, practice, there's no interaction with, your DNA or your eggs or ability to reproduce. So that is a question that comes up, pretty frequently, and people are understandably hesitant before they jump in, for a decision like this.
There are two other questions that popped up, one on boosters and one about long haulers. Why don't we postpone those towards the end? But these questions are great. Let's keep it going. We'll go through a few more slides first.
So we'll talk about influenza, which, we kind of forgot about influenza, or I forgot about it. As we were preparing for this, I realized, or thought about again, I have not seen a single patient with influenza in 2020. So, nearly 2 years now since I've seen a single case of influenza. That's probably the experience that most of our ER doctors have seen as well, and primary doctors. And there's a lot of similarities, I think, that are important to mention. It's a virus, just something that does not respond to antibiotics. It's caused by influenza A or B virus typically, and also like COVID, spread mainly by respiratory droplets, but some role for aerosolized spread. Also, like COVID, you can have some asymptomatic spread. It's a little bit of a shorter period of time of asymptomatic spreading. And the illness is a little bit shorter, typically 5 to 7 days instead of, a 10-day illness and 10 days of transmission. The symptoms are very similar: fever, headache, body aches, fatigue, coughing, sore throat. And the complications are similar. You can have a primary pneumonia, meaning a viral pneumonia, which is just consolidation or density in your lungs from the viral infection, or a secondary pneumonia, very similar to COVID, where you have your viral infection, and then as your body's recovering, bacteria come in and take advantage of a weakened state. And then inflammation of the muscles, myositis or rhabdomyolysis, heart attacks, heart failure, inflammation around the heart, myocarditis, pericarditis, all sounds pretty familiar. Encephalopathy is an inflammation around the brain, and in the brain, transverse myelitis, the nervous system, meningitis, same thing. Guillain-Barré is a nerve inflammation, really. So very similar symptoms, complications. I think probably, the most striking difference is COVID tends to cause a lot more inflammation in the body after the infection. The effects are longer and tend to be more severe.
I'd say for me, the biggest the biggest difference between flu and COVID is that COVID tends to be a lot more dramatic. And scientifically speaking, it's because the flu has been in, I guess, synergy with humans for thousands of years, and has learned to do what it needs to become the virus that it is. Infections like the flu will learn not to be as lethal as previous strains, because ultimately the genetic drive is to replicate the virus, not to kill the host. Whereas unfortunately, when you get a new infection like COVID, or in the past we've had Ebola or HIV, the fatality rates are markedly higher because the infections haven't learned to adapt to a human host on a consistent basis. I have seen a lot of flu patients in the past, but very few of them have been so dramatically ill, so critically unstable as the COVID patients I've seen in the past year. One ER doctor said that the big difference for him was that he had plenty of COVID patients dying in the emergency room, whereas that was almost unheard of in his long career. That's a relative rarity. And so for me, the COVID is far more dramatic in that regard. And again, it ties into the genetics. This slide popped up because we wanted to mention that flu is around every year. And it's something that has, again, attenuated. We do get sick from it every year. It is a scourge that we deal with. It's what we call an endemic infection. Every so often, there is a change in the genetics of the flu that causes it to tweak dramatically so that it's very different from the flu that we've experienced the year before. Typically, there's only minor variations, so your body vaguely recognizes it, and so you get a regular case of the flu. But when there's a big shift in the genetics, you get the pandemic strains. The big one that we had in 2009 that killed, I don't know how many hundreds of thousands of people, that was swine flu, H5N1, I believe, or H1N1. So they occur fairly routinely, and these mini pandemics occur a little bit less frequently. But again, the COVID that we experience now is really on par with anything in our medical history. It's on par with the Spanish flu of 1918, that affected hundreds of millions of people and killed probably somewhere between 25 to 50 million. And in terms of scope, the only reason that it's only killed about 4 or 5 million, COVID has only killed 4 or 5 million, is because it's slightly less lethal than what we experienced in 1918. And science, medicine, and public health has improved dramatically in the past 100 years. So the flu is still there. We will still experience it. It is coming back on a more routine basis, but it's still a scourge. And what we worry is that COVID will become an endemic infection similar to the flu. If you go to the next slide, and the impact, typical annual impact from the flu is that it kills 12 to 50,000 people a year, but it hospitalizes hundreds of thousands of people, and millions get sick in the US alone. If we go, how do we protect ourselves? Dr. Cohen, I think you want to tackle this one, or you want me to keep going?
Yeah, I mean, I think the interesting thing is that the way that we protect ourselves from COVID happen to be moderately effective against COVID, but incredibly effective against flu.
Yep.
To our point about the extremely low flu numbers that we saw in the last year and a half. But at the bottom is get vaccinated, and I think goes without saying for us that is the top 1, 2, and 3. But the mask wearing, washing hands, avoiding crowded spaces. We'll need to learn how to adjust this as we feel that we're safe and our families are safe, and rates in the population go down and hospitalizations go down. I don't think we're going to be wearing a mask in the supermarket forever. But these are the things that will tend to prevent other people from getting sick and help you from getting sick. And one thing I would add in here is when you're ill or when you've had an exposure, make sure that you're getting a COVID test. And now they are available at all the local drugstores. You can buy a pack of 2 or a pack of 4. And again, as somebody with 2 little kids, it's something I do somewhat routinely on my children. Is when there's a runny nose or when there's a potential exposure, yes, the school may need a PCR for their verifications, but I'm testing my kids relatively routinely, because before we go over for that play date, if my kid had a runny nose 2 days ago, I just want to be sure. And that's also, I think, an important way to protect ourselves and protect others.
And Evan, someone just asked, relevant to this, how reliable is that antigen test kit?
Yeah, they're really good at detecting transmissible infection. So there's kind of 2 main ways that we test. One is a PCR, which typically you're going to see at a hospital or a lab or an urgent care, which are in the high 90s and are really good at detecting viral particles even when you're not actively infectious to other people, but also really, really good at detecting that pre-symptomatic phase. Then there's the rapid antigen tests, which are pretty readily available, usually $5 to $10 at the pharmacies. And those are really good in the mid 90s at detecting active infection with transmissible illness. So it may not pick up that pre-symptomatic spread, which has value as well. But if I'm sick with a runny nose and a cough, that's highly reliable if that test is either positive or negative. So it kind of has to be taken in context. Again, not quite as good for that asymptomatic, or maybe you had symptoms 11 days ago. It's probably not as good as the PCR, but depending on the circumstance, I think they're a valuable tool.
And I wanted to echo a point you were commenting on. It. These are all different things that you can do to help protect yourself. Again, as we're learning more, we're trying to find the balance between risk and benefit. You ask 1,000 doctors what they would do and what are the ways they would help, that they would protect themselves. And when it comes to vaccines, they're almost, over 97% say I would definitely vaccinate myself and my family. And then as you look at other techniques, watch how often do you wash your hands? That number is still pretty high. How often do you wear your mask? A little bit lower than washing your hands, but still pretty high. What considerations? When do you wear your mask? You know, not many doctors will wear their mask when they're going jogging out on a trail. In fact, almost none of them. But if you're going to a concert or if you're going to a crowded restaurant, you wear it. You know, many of us will wear it. And it's all degrees of how much risk you're willing to accept for yourself and to those around you. So these are all, I guess what I'm trying to say is that there's a great area, there's great spectrum of gray in terms of what the right thing to do is. What we're trying to tell you is these are the things you can do to protect yourself, and how often you implement that is really up to you.
Yeah, I think it's gotten more tricky because in the beginning, March and April, I think the strategy, nationally and globally was really as much protection as possible at almost all costs, which meant, mask everywhere, no 6-foot interactions. And as we've had, vaccines out and things are a little bit better controlled, there are a tremendous amount of nuances. It's a much different scenario for you if you're 30 and healthy and have no children, and aren't really responsible to others versus if you live with your 90-year-old grandmother who has cancer, or live with your unvaccinated children, or there's just so many nuances now, and it's kind of impossible to predict or dictate everybody's own risk, so it is pretty tricky.
More questions that we'll get to at the end, we promise. We won't forget you. Go ahead.
Yeah, so this is just, I think with the Delta variant, people are concerned, and with the news, with recommendations of boosters and third shots, the vaccines are still working phenomenally well. That's the bottom line, is that unfortunately, yes, what we were calling breakthrough infections are possible and are, somewhat common. I happen to have a good friend now who has a breakthrough infection where he's double vaccinated and still got COVID and felt lousy for a few days. But the risk of infection is dramatically lower if you've been vaccinated. And the risk of hospitalization and death still remains dramatically low for most people that have been vaccinated. Dr. Ahari and I see, the numbers every single day in our community. And it's almost exclusively unvaccinated folks that are getting admitted to the hospital. And the exceptions with the vaccinated are those with severe immune compromise and at extremes of age, extreme elderly, or with serious underlying medical problems like severe COPD or diabetes or cancer. So there are still vulnerable populations out there despite vaccines. But as a generality, the vaccines have remained incredibly effective, even with Delta variant out there circulating.
Brenda has a question. Why don't we hit the next slide real quick, and then we can bring up her question. Are the vaccines safe? we can't put this any simpler. So Brenda's question is, and ties into this, what do you attribute the large number of healthcare professionals' refusal to get a vaccine nationwide to? Again, as an epidemiologist before I was a physician, oftentimes one of the things that we would have to contend with in a pandemic or epidemic sort of situation is PR, public relations, and media communication. 97% or more physicians are unequivocally vaccinated or plan to get vaccinated as of March. Probably that number is higher. About close to 90% of all nurses in the US are vaccinated or plan to get vaccinated. And I think that was as of about 2 months ago. It is hard, it is almost impossible to get 10 physicians to agree on what color the sky is. And so 97% or greater agreeing that the vaccination is the way to go is an overwhelmingly strong endorsement of the vaccine. And so the question is, what do you attribute this large number of healthcare professionals that refuse it? I really attribute it to poor media, data data interpretation. It's a far more dramatic news story to hear about the one doctor who thinks vaccines will give you herpes or what other ridiculous concepts are going out there than it is to hear about the other 99 who rather conservatively and pretty mundanely say, you know what, vaccine's really your best bet. So it's a lot of noise, but not a lot of substance. Is what I'm getting at.
Yeah, I agree. And I think you said this, Dr. Ahari, to me last time is, if you have 100 experts in a room and 99 of them, think the sky is blue and one of them thinks it's green, you're probably better off going with the 99 when you make your decisions. And I think there's so many factors for so many people, but, I think the biggest one is I don't think people like being told what to do by others. And I think that as human beings, it's incredibly hard to have your mind changed about something you feel passionately about. So if you start with a false premise or an uneducated premise, it's going to be very hard to change my mind. And I go through this exercise with friends. When is the last time my mind was changed on, other intense subjects? Abortion, legalization of marijuana, seatbelts in cars. It's
Religion and politics.
Yeah, my opinions have been relatively stable, for most of my life, and it would be pretty hard for anybody to change my opinions on, something that I've given a lot of thought to. So, it's very hard to change opinions. When I meet a patient, I always try to ask if they're vaccinated, and if they're not, I just ask if they have any questions about the vaccine. And nobody got to that opinion that vaccines are bad because they want to be harmful to others. So it's an opportunity for an open-minded, non-judgmental conversation. And 1 out of 3, somebody says thank you for taking the time to explain your opinions, and maybe 1 out of 3 of those will get a vaccine, and I feel good about that.
I guess also as a scientist, I can say that, again, to reiterate, we don't know much about the vaccines or the virus. It's only been 2 years. But we do know we are learning a lot every day. And we can't offer guarantees. Our opinions as scientists will change based on what evidence is out there. And if I see good evidence that suggests that my ideas that I've learned are wrong, then I'm happy to change that opinion. I'm happy to change that perspective based on the information that's available. And so you work with what we know.
Absolutely. I'll leave this. I think this one is for you. Oh, it's for me. So just talking about safety, more. I mean, I think it's an incredibly safe collection of vaccines. Right now between the J&J, the Pfizer, and the Moderna vaccines. The side effects that we worry about are anaphylaxis, meaning a severe, life-threatening allergic reaction. I've seen 0, and I've heard of 0 locally, but that's certainly a possibility. And then there was a lot of news media about this thrombosis and thrombocytopenia syndrome, where getting blood clots in the brain after a J&J vaccine, and that is an incredibly rare side effect, but I think meaningful enough, and with enough alternatives, that there are certain people that if they ask me, I would say it may be better for you to go ahead and get one of the mRNA vaccines. So especially young women, where people that are on birth control or have had previous blood clots. Just for transparency, I've never seen a case of this thrombosis syndrome after J&J vaccine either. Long-term side effects, are extremely unlikely. And again, we'll know in 10 years, but based on the science of how these vaccines work and the fact that the message that the mRNA vaccines send to your body, really goes away pretty quickly. And all you're left with is, a memory of it, which is antibodies and cellular immunity. I don't expect that we'll end up seeing a lot of long-term side effects or any. And as a reminder now, anyone 12 and older can be vaccinated with Pfizer, and 18 and older for Moderna and J&J.
We wanted to mention herd immunity, since this is a concept that's brought about in the news fairly often. And it's a rather complicated concept that, if you understand it, also brings about the understanding of the implications of your choices, not only on your own health, but on your community's health. As Dr. Cohen mentioned, the virus will infect you. It targets all the different organ systems in the body. It's got preferences, but it basically commandeers your cells to reproduce the virus. It's got its basically making your body into a factory. If you look at the pictures, the top two pictures with the people, those in a community that are not immunized, you'll see that the single red person at the bottom of the square is pink. They are a contagious unvaccinated patient. The blue are healthy unvaccinated patients, and the yellow, there's only 2 or 3 in that box, are the vaccinated population. What that means is that single infected person at the bottom of the square is now a factory for reproducing the virus and can potentially transmit the virus easily into the rest of the community who are unprotected. You can see that it's so overwhelming that you basically become the point of infection for the community and spread it to the rest of that community. It's a bit of an exaggeration about what actually happens and a simplification, but that's the concept, meaning that one person is the vector to get the rest of the community ill. In an immunized population, even if you do get infected, even if there is a single point infection, you can see one pink circle in that square of mostly yellow people. The virus can commandeer your body, but can't find valid targets to infect since your community is primarily vaccinated. That's the concept of herd immunity. When the community as a collective whole reaches a threshold that they are not only protected as individuals, but they slow down or reduce the transmission to other people in the community, that's when the virus fails to reproduce and continue its life cycle. Now, you can still get sick if you're vaccinated, but your ability to actually infect others goes down dramatically as well. So the whole idea is, not only does vaccination protect you from getting infected, protect you from getting severe disease, protect you from dying, but also protects you from getting the infection and giving it to other people in your community or in your household. That's the concept. Here we see that over 6.5 billion doses of the vaccine has been administered. These numbers are going up dramatically, but in the US, our numbers are kind of hitting a plateau. Only about 2/3 of the New York population is fully vaccinated, but we've gotten 26 million doses out there, meaning that there's a lot of people who've gotten one dose and really haven't successfully completed their course. Again, over 96% of US doctors are vaccinated. That's a conservative study. Other studies suggest that number is higher, but the point is that the people who are dealing with the infection, the people who have to deal with this on a fairly routine basis, see the value of vaccinating themselves and their families. But there's a lot of hesitancy and a lot of concern about and questions about the vaccine, which hopefully we're able to provide some information regarding. You want to hit this slide?
Yeah, I mean, I think that at this point, the vaccine should be really readily available. Your local pharmacy, supermarkets, you can go through the New York State Vaccine Finder. There has been a lot of discussion about boosters and third doses recently. And so I want to touch on that to the best of my ability. Although I believe even today or yesterday, the news changed again. So it's hard to stay on top of it. But, the short of it is that in the past few weeks, Pfizer was approved for third doses or boosters rather, for those that are vulnerable, over 65, have significant health conditions, or have essentially high exposure jobs. So that included healthcare workers, but also I believe, people that are working in grocery stores and, other things where you're very public facing. They also included pregnant women in there as a high risk population that they advised for a booster shot if it had been over 6 months since your last shot. Moderna, I believe, was just voted to have the same approval. And I don't know if that's official yesterday or the end of the week, but over the next few days, that would be my expectation, that you'd be able to go to your pharmacy and get your booster of Moderna. Right now, and this is probably going to change as well, if you had your first, series was with Moderna, your booster should be Moderna. If your first series was Pfizer, etc. Although there is, likely to be some recommendations on mixing and matching in the future, I don't think that that's the current recommendation as of today. But tomorrow the answer may be different. And J&J, I would expect to hear that J&J will be recommending boosters in the very near future as well, for those populations. A third dose is different than a booster. That means that you had a severe immune compromised condition, maybe cancer, rheumatoid arthritis, a transplant of a liver or heart, and you were on medications that prevented your body from mounting an immune response. And so those people were recommended to get third doses, meaning we didn't think that the 2 was going to be enough and you should have a third. And that's different from a booster, which means it's been 6 months or longer since your last shot, and your antibody immunity may be waning, and it may be time to get a booster the way we would for pertussis or tetanus, shingles, pneumonia. The concepts are the same, is that those boosters probably make your immune protection more robust. I do want to reassure people that even with the 2 vaccines, although you may get a breakthrough infection, you may feel lousy, the protection against hospitalization and death from just the plain old 2 shots still remains very robust and very protective. I personally did get a booster because I am surrounded by people with COVID all the time, and I feel that my exposure risk is high. And if I could choose to get sick for 1 or 2 days versus 7 days, even though I'm not worried about hospitalization for myself, I would much rather have, the 1 day of illness or the really mild illness instead of the moderate illness. And then, also importantly, it is the start of flu season, and we don't know if it's going to be a flu season like 2020, or will it be something different or, more severe because of the break and the flu, illness. So please get your flu shots as well.
And there's a couple of questions regarding vaccines. Should we address them now? We've only got 3 more slides to go. Do you want to wrap up the slides, or you
Okay, why
want
don't we try to get through and then get to as many questions as possible? So
Okay.
I'll go quickly. Just a plug for monoclonal antibodies, which is a medication that can be used really early on, like the first 7 days of illness. And it's essentially synthetic antibodies that can help prevent progression of disease. That's something generally is being given in hospital setting, emergency departments, or through a clinic that's set up to do that. We have antiviral medications that are being given in the hospital, steroids. Antibiotics generally is not a mainstay of treatment of this because it's a viral illness. And then there has been some exciting news over the last few weeks over long-acting monoclonal antibodies and an antiviral pill Neither of these are approved and in mainstay of treatment at this point, but over the next few weeks or months, we expect to see some more news on this.
Excellent.
And is the Delta strain different? I think what's most different about it is how readily it spreads. The severity may be slightly worse. The vaccines remain, quite effective against protecting against severe illness, but it does seem to spread more rapidly than some of the previous variants. And we will see more variants of this disease in the future. That's what viruses do; they mutate, and we may see endemic mutations every year, as we do with the flu. That's for the future to tell us.
And what does the future hold? I think a couple of things that you already mentioned, but the more infections, more people get infected, the more bodies are converted to virus factories, the more opportunities the virus has to mutate into something more infectious or more dangerous. Really, we're kind of at a crossroads where we will see the virus either slowly eradicated, which seems unlikely at this rate of management that we're doing as a society, or more likely this will become an endemic process, kind of like the flu, where we'll see the virus come back in ebb and flow. There'll be peaks and troughs. And whereas the flu kills 50,000 people a year, 25 to 50,000 people a year in the US, who knows what COVID is going to look like in 2-3 years in terms of periodic infections. The only obvious societal remedy we have that gives us a chance for success in completely preventing this infection is vaccination and developing that herd immunity, where we collectively agree that this is what we're going to do to prevent the transmission and really stop that arms cycle that happens every time the virus takes over a human body and turns it into a virus factory.